Gastroesophageal reflux disease. It is the reflux of gastric contents up into the esophagus, causing inflammation of the esophagus, also known as reflux esophagitis. There are two factors that prevent the gastric contents from moving up into the esophagus: the diaphragm and the lower esophageal sphincter. In contrast, the intra-abdominal pressure favors gastric reflux. So factors that affect diaphragm, like hiatal hernia, or that decrease LES tone, like hypothyroidism, CNS depressants, smoking, or Heller's myotomy, and increase intra-abdominal pressure in pregnancy, obesity, and large meal causes GERD. Hiatal hernia is a cause of GERD because normally the lower esophageal sphincter is wrapped around by hiatus of the diaphragm. In hiatal hernia, it moves up and GERD can occur. Note that some degree of reflux is normal, as we all have experienced. This occurs when LES relaxes transiently during food digestion to release the air swallowed. It is also known as belching. The clinical symptoms mainly include heartburn and regurgitation. Apart from this, other symptoms occur as well. All the symptoms occur due to three mechanisms involved: the food and acid content that moves up into the esophagus, into the mouth, and into the trachea. Up into the esophagus causes heartburn or burning chest pain, and esophagitis that causes odynophagia and dysphagia. When the acidic content of stomach moves up into the trachea, it causes four things: a cough, laryngitis, asthma due to bronchospasm, and recurrent chest infection. The acidic content can move up straight into the mouth, and it can lead to dental erosion as well as water brash, which is known as thravi uba in Pashto, and it is the release of saliva in response to gastric acid. The chest pain in GERD is known as atypical chest pain since it does not meet the criteria for typical chest pain or angina, which is substernal, relieved with nitrates, and aggravated with exertion. The pain in GERD is only substernal. The diagnosis is mainly clinical, but endoscopy, manometry, pH monitoring, and barium studies can also be done. Endoscopy not only confirms GERD and its complications, but also excludes esophageal adenocarcinoma that can occur as a result of long-standing GERD. Endoscopy is most widely used in certain cases. Manometry and pH monitoring can be used. In manometry, decrease LES tone, and in pH monitoring, acidic pH in the lower esophagus confirms GERD. In pH monitoring, we pass a probe through the nose down into the esophagus, just above the LES. The lower end of the probe detects changes in pH. This probe is left for 24 hours within the esophagus. If it shows acidic pH in the lower esophagus, GERD is confirmed. Rarely, barium meal can also be used, and simple reflux of barium solution into the esophagus confirms GERD. This barium study or barium meal shows how the barium solution that has once reached into the stomach moves up and shows reflux. The second and third shows higher degree of reflux. Diagnostic algorithm of GERD. This means that a person with GERD does not undergo all the investigations. The diagnosis is always clinically in most cases, and when a person comes to you with heartburn and regurgitation, the clinical typical symptoms of GERD, we label him as GERD and we give him empiric proton pump inhibitors, and we do not do any investigation. But if his symptoms persist or he has alarm features that indicates complications of GERD like carcinoma, such as he has increased age, he has weight loss, anemia, and troublesome dysphagia, only then we move on to endoscopy. In endoscopy, either we'll confirm GERD all at once, or the diagnosis won't be certain. If the diagnosis is still doubtful and uncertain, only then we move to the further two investigations like manometry, which measures LES tone or pressure, and pH monitoring, which measures the pH in the lower esophagus. The treatment of GERD includes three things: lifestyle modifications, pharmacological treatment, and surgery. Lifestyle modification is simple: weight loss, elevation of the head of the bed using extra pillows, and eating non-spicy. Pharmacological or medical treatment aims at decreasing the gastric acid that is produced in the stomach to reduce the chances of esophagitis. Using proton pump inhibitors, omeprazole, esomeprazole, that directly block the proton pump that forms HCl, and histamine or H2 blockers, including cimetidine and famotidine, that block the histamine receptors present on the parietal cells. Parietal cells are present in the lining of the stomach. They produce H plus or protons into the lumen of the stomach. These have histamine receptors. PPIs block proton pump, whereas H2 blockers block the histamine receptors, and both thus decrease the HCl produced. Surgical interventions include two things: fundoplication and partial gastrectomy. In fundoplication, the fundus of the stomach is held and it is simply wrapped around the lower esophageal sphincter to strengthen it so that no reflux, so that food reflux does not occur. It may be total, in which the fundus is completely wrapped around the lower esophageal sphincter, but it leads to overcompetent cardia, so it is not preferred. In partial, the LES is partially wrapped by the fundus. The diagram shows how the fundus is wrapped around completely in Nissen, also called total fundoplication, and Dor, a partial fundoplication but done anteriorly, and Toppet, partial fundoplication but done from posterior aspect of the esophagus. In both these Dor and Toppet, these partial fundoplications leave some part of the esophagus unwrapped, and it is preferred over Nissen. In partial gastrectomy, as the name indicates, half of the stomach is removed and it is discarded, and the remaining stomach is attached to jejunum. It helps in reducing the gastric acid that is produced. This is a related scenario. A 24-year male smoker presents with retrosternal burning chest pain. It is also known as heartburn, and he also has pain epigastrium for the past 2 months, or atypical chest pain. Symptoms are provoked by fatty food, alcohol, and citrus drinks. Along with these, caffeine and chocolate also aggravate the pain in GERD. So this clearly shows that it is GERD.